The rationale of combining atezo and bevacizumab is the same rationale of combining VEGF inhibitor with IO-based therapy. Bevacizumab is an IV available antibody against VEGF, so there are some practical advantages to giving two IV therapies to a patient and having them avoid taking an oral therapy at home. There's nothing else more unique than that as far as why they work. So I think it has been one of the first reported combinations that really proves the principle that VEGF inhibition with an IO can actually potentially raise efficacy and accomplish what we need to. It's unclear to me that the patient population reported on with results that good and intermediate risk makes that combination unique to that setting, or whether we will see the agents that we've already studied, the ipi/nivos and the cabozantinibs, which have shown benefit in the intermediate and poor risk, whether they would translate into that same space. I have seen nothing, and I'm aware of no underlying biology that would suggest that there should be a difference between the different prognostic groups. The million-dollar question is whether or not the combination of atezo-bev, if it received regulatory approval, would be given or uptaken in the community oncology practice. And it's unclear to me whether or not that will happen. I think there's several factors involved with that. Obviously, the price of the medication, chair time, so many other extraneous factors that are involved in a community oncologist when they're trying to decide treatment options, and cost to patient are going to be important.
The combination of an anti-PD-1 with an IDO inhibitor has been of great interest within the immuno-oncology community. This is based off of the role of kynurenine as an oncometabolite that suppresses T-cell activation. Tryptophan is metabolized to kynurenine by the enzyme IDO, and IDO being the rate-limiting step, inhibitors of IDO are thought to enhance T-cell activation. This has been studied in multiple malignancies, including originally proposed the phase 3 clinical trial of epacadostat plus pembrolizumab for metastatic RCC randomized against sunitinib. However, recently, based off of the results presented within melanoma, the combination of pembrolizumab plus epacadostat didn't reach its primary endpoints, and therefore there's been a bit of pause in what the role of IDO inhibition will end up being in combination with PD-L1 inhibitors or PD-1 inhibitors.